I'm the Special Events Coordinator here at the Mirowitz Center. We are delighted to welcome all of you today, and especially to welcome Alan Spector. Since he retired from Procter & Gamble as a Director of Worldwide Quality Assurance in 2002, Alan has authored 8 books, including Cancer, Balancing Reality and Hope, which is what he's going to be discussing with us today. When he is not writing, he is a strategic planning consultant for local nonprofits and large cancer organizations, and he speaks across the country and blogs about retirement life planning. Alan continues to play baseball with kids of his own age in local leagues, in winter tournaments in Florida, and he has also played internationally. He's a community volunteer, a gym rat, an avid crossword puzzle solver, and an active and proud grandfather of 4. And he and with his wife Anne, they travel extensively, both for pleasure and to see their family. I think we should also add and acknowledge that he was recently selected to be one of this year's unsung heroes, a well-deserved honor of which we're all very happy for you. And now it's my pleasure to welcome Alan back for this program at the Mirowitz Center. Thank you, Alan.
Well, thank you, Stephen. It's really great to be here. This is my third time working with the Mirowitz Center at Covenant Place, and I've enjoyed all the previous sessions, and I'm really looking forward to this discussion as well. I'm going to share my screen. I have some slides that you can see as we move along here, and I'll remind you again later that we're going to have time for Q&A at the end, and so if you have any questions, hold them. What we'll do is unshare the screen so we can see each other, and if you have any questions or comments, that would be great. It always adds to the conversation when I'm not the only one speaking here. So let me just confirm. Can I get a thumbs up that everybody see the shared screen? We okay? All right, great, thank you. To get started here, let's get real clear. Let me get this started here. Sorry about that. Okay, there we go. I'd really like to thank Stephen and Judith and Susan for putting this all together, and not only this session, but all the other sessions that they create for our community benefit. Thank you to you all for what you do. It's just great. Now, in a perfect world, we'd love to be face to face and together. We're not in a perfect world. So we just have one more virtual session to go through, but I think we've all become pretty used to those. So if you're ready, I'm ready. If you can see the screen, I'm the clown in the lower column there. So the rest of you can decide which of those faces you want to be. So I normally don't read from my books when I'm discussing them, but I think it's appropriate for me to start our discussion today by sharing with you the first part of the introduction that I wrote for Cancer, Balancing Reality and Hope. So let me do that. And I think it'll begin to give you some perspective that I'll get into a little bit more deeply later on about why I wrote this particular book and why it may be of interest for you. So let me start with that part of the introduction. Have you had a cold? No. Have you had an infection? No. Not that I know of. Why do you ask? Well, your white blood count is slightly elevated. Let's make arrangements for you to see a hematologist just to make sure everything is okay. This was an exchange between my primary care physician and me during an annual physical in 2010. Fast forward to the appointment with the hematologist. As I stride down the hallway, I'm focused on looking for his office. Having no concerns, just another routine check. Why be concerned? I feel great. Physically fit, spending 2 hours in the gym 4 days a week. Age 64, still playing baseball. No, not softball, baseball. This is just another doctor's appointment, just to make sure everything is okay. I find the office suite, enter, and am dumbstruck by one of the words above the receptionist window, oncology. In the next hour, my blood is drawn, centrifuged, and analyzed, and I am now sitting in the hematologist's office listening more than intently. In a gentle, caring tone, he explains, white blood cells are created in the bone marrow, sent into the bloodstream to circulate around the body, poised to fight infection. If there is an infection, the body generates even more white cells. Inside each of these white cells is a switch that eventually kills it off to make room for others. In some people, these switches stop working. We can tell from testing your blood using flow cytometry whether your high white count is a function of more cells being created to fight an infection or a function of the switches not working. In your case, the switches aren't working. Your white cells aren't dying off the way that they are supposed to. In and of themselves, these extra white cells in your bloodstream and bone marrow are not an issue. However, if the counts increase sufficiently to be crowding out healthy white cells, red cells, and platelets, that can become a problem. If that happens, we would need to treat the condition. For now, the best thing to do is monitor your white count and other blood markers every 3 months to see how the numbers are progressing. This is all making sense. It's logical. It's scientific. I get it. I've got this condition. We'll monitor it. If need be, we'll treat it. He's calm. I'm calm. Then, before asking if I have any questions, he says, there's a name for this condition. It's called chronic lymphocytic leukemia, sometimes referred to as CLL. Wait, what? Leukemia? Isn't that blood cancer? My logical engineering mind is now in conflict with my emotional, what do you mean I have cancer mind? Just as my white cells are now at war with the rest of my bloodstream. I've frequently heard the term battling cancer, but now it's about me. And already I'm engaged in battles, none of them by choice. When I get home from the doctor, my wife Ann reacts to the news with a comforting calm. Later, she tells me that she was able to appear calm because I had shared the details with her as the doctor had explained them to me. By the time I got to the word leukemia, she was convinced that I knew that what we needed to do and felt that I believed everything would be okay. She also tells me that it went through her mind that if she weren't strong, I might feel as though I need to attend to her when I should be fully focused on attending to myself. Shortly thereafter, that hematologist retires and I begin seeing Dr. Nancy Bartlett at the Excitement Cancer Center in St. Louis, where I live. 3 months after my first appointment with her, and after a lot of reading about CLL, I returned to Siteman, but I'm early for my scheduled blood draw and hands-on checkup to look for enlarged lymph nodes. In the few minutes I have before heading toward the lab to have my blood drawn, I'm standing in front of the floor-to-ceiling windows at the Cancer Center, overlooking the busy intersection of Forest Park Parkway and Euclid Avenue. Among the pedestrians and drivers going to work, appointments, and wherever, there were about 100 people in my sunlit morning view. Based on what I had learned from my reading, I realized that about 40 of those 100 people either already have been or will be diagnosed with some form of cancer in their lifetime. And virtually every one of the 100 either knows of or will know a relative or close friend with the disease. When experiencing the life-changing diagnosis, each of the intersection people and each of us, whether survivor or loved one, is confronted with three things simultaneously. There is the reality of the disease with all of its physical implications and its required decision-making. There is the inevitable rush of emotion, and there is the beginning of a relentless search for hope. I just used the word survivor for the first time, so let's pause for a moment to establish the definition that we'll use interchangeably throughout the book with the word patient. The term survivor has meant different things over the years, but currently, According to the National Cancer Institute of the National Institutes of Health, a person is considered to be a survivor from the time of diagnosis until the end of life. The definition is irrespective of the type of cancer, whether the cancer is acute or chronic, what its stage is, and what the prognosis is. It doesn't take into account how the person is tolerating or responding to treatment or emotionally coping with the disease. Basically, if you have been diagnosed, you are, by definition, a survivor. Until this book was published 9 years after my diagnosis, only my immediate family, my medical support team, a couple of close friends, and a number of cancer researchers knew about my CLL. But this book is not just about my coming out. Rather, it is about my mom, who died of ovarian cancer, and my dad, who died of lung cancer. It is about my mother-in-law, who is a 10-plus year ovarian cancer survivor, and my brother-in-law, who is a 15-plus year colorectal cancer survivor, with whom his doctor has used the word cured. It is about the too many relatives, classmates, friends, and others I know who have been diagnosed and are either survivors or not. It is about my youngest sister, who is a dedicated and tireless nurse, just like our mother, and my middle sister, who courageously and compassionately counsels others about grieving, death, and dying. It is about all the spouses, partners, parents, children, and friends whose loved one has been diagnosed. It is about all the dedicated people in the cancer research and care community, many of whom you'll meet throughout the book, as they have taken time to share their insights. It is about all of the countless volunteers and donors and fundraisers and advocates who give of their time, talent, and treasure to make a difference in our lives. And it is about those 100 people outside the Siteman Cancer Center windows. Among them were likely researchers, cancer researchers, doctors, nurses, caregivers, and survivors. There was likely a father or mother or brother or sister or friend who had lost or would lose a loved one to the disease. And there were also likely many who were not yet affected. Someone on his way to the corner coffee shop, a financial advisor on the way to her office, a construction worker going to the nearby site on which a hospital was being rebuilt. But mostly it is about those living with cancer and those who love them, the spouse of someone newly diagnosed, the parents of a child survivor, a friend who learns of a diagnosis from 1,000 miles away. So that section of the book, of the introduction, begins the book. And although we'll be talking about the disease called cancer, the concepts that we'll be discussing and that you'll find in the book can relate to any of the serious diseases we or loved ones might face. So in our discussion, we'll talk a bit about cancer in general. Then I'll share with you why I thought it was important to write this particular book. We'll then finish by discussing several of the key concepts in the book that may be of particular interest to you. So before we continue, let's acknowledge up front that cancer is a difficult subject to talk about and to write about. But let's also acknowledge that the more we talk about it and the more we learn, the better we can deal with it, whether we are a survivor or a loved one. We may or may not have time for questions or comments. I suspect we will. So again, as I mentioned before, please hold them until the end. And again, both questions or comments will be more than welcomed. And as I said, I'm confident that we'll have time. That being said, if we don't have time, or if in fact there's a question or comment that you have that you prefer not to share openly with everybody, that's fine. I'll provide you with my contact information, and you can get in touch with me separately. I would look forward to that. So let's get started. So I have good news and bad news. The bad news is that we are all likely, sometime in our lifetime, to be touched by cancer in some way. As I noted earlier, greater than 40% of us will be diagnosed in our lifetime. And age is a significant cancer marker. 77% of cancer diagnoses happen after the age of 55, and 53%, 53% among those over 65. The good news is that there's been remarkable strides in the treatment of most cancers, and this has led to a much better survival rates. For example, from 1975 until 2010, the 5-year survival rate of all cancers improved from 30% to 68%. And since then has continued to improve by about 1.5% per year. And in the same time frame, the 5-year survival rate for the most common cancers are up significantly. Breast cancer is improved by 90%, prostate cancer by 100%, colorectal cancer improved 67%, and bladder cancer improved 81%. Some more good news. Pediatric cancers, those of children 15 or age 15 or younger, are no exception to the improvement. In fact, they may be viewed as leading the way. In the mid-1970s, the 5-year survival rate for pediatric cancers was 58%, and by 2011 was up to 83%, and those numbers continue to improve. Dr. Louis DeGennaro is the president and CEO of the National Leukemia and Lymphoma Society, and he was kind enough to write the foreword for my book. Dr. Lou, as he is known, wrote, "The reality is there is never a good time to get cancer, but the hope is that now, today, is a phenomenal time to be fighting it. There is increasing optimism that we are on the cusp of curing cancer, what has been called the emperor of all maladies." And by the way, if you're really deeply interested in cancer as a subject, either for just curiosity or for wanting to learn more about your situation or a loved one's, even though it's a long read, get the book, The Emperor of All Maladies. It does, in fact, walk through the history of and what's going on currently with cancer and cancer research and cancer cure. So as I mentioned, I lost my mother and my father to cancer. My mother-in-law and brother-in-law and other relatives and friends are long-term cancer survivors. And I've lost classmates and friends, as we all have. You likely are listening to this thinking about someone or someone's as well. So we've established that virtually everyone will be affected, either as a survivor or a loved one. You will likely have, and the subject matters to each of us. So let's move on to why I thought it was appropriate for me to write this particular book. After my 6th book was published, I was searching for a topic for book 7. There is a saying in the authors community, write what you know. I recognize that I may have a unique set of perspectives that allow me to do just that for this book. What I read to you from the introduction gives you a sense of one perspective. The subject of cancer would be personal to me. The second perspective that helped me write what I know began about the same time I was diagnosed. I began doing strategic planning, as Stephen mentioned, consulting with large cancer organizations around the country, including the Lombardi Cancer Center at Georgetown University, the University of Colorado Cancer Center, and the organization called Fight Colorectal Cancer, among many others. Their insights, this enabled me to develop a broad network of cancer researchers, medical professionals, and others in the cancer community, many whose insights are featured in the book. Their insights provided an interesting perspective on what it's like on the other side of the cancer diagnosis and treatment discussion. And they shared their perspective on how research is done and why it sometimes works and sometimes doesn't. By the way, there's a number of other people whose insights are shared in the book. Thanks to some of the folks who were on our Zoom session this morning and many others who were willing to be interviewed for the book and allow their cancer experience profiles to be shared in the book. So thank you to you all who were on the Zoom call that allowed us to do that, and for allowing me to share your experiences in the book. So personal cancer experience, the strategic planning consulting with cancer organizations allowed me to build a network. But there was a third perspective that came together with those two other perspectives, that allowed me to write the book and write what I know. I've been doing some work for about 2 decades, and it was the opportunity I've had the opportunity to study, write about, and speak about retirement life planning. Now, how is that related to thinking about cancer? Well, fortunately, the life planning principles for retirement also apply to life planning in general and to life planning for those with cancer. We'll talk more about that concept in a little bit. So the bottom line is that cancer, balancing reality and hope, gave me the opportunity, because of a combination of perspectives, in fact, to write what I know. So although the title and the subtitle of the book are Cancer, Balancing Reality and Hope for the Newly Diagnosed and Those Who Love Them, Dr. Liu had a different take on what it could have been. In the foreword, he wrote, "The title could very well have been Cancer, How to Think About What to Think About." There are many key concepts in the book, but there are 4 I'd like to share with you today to help us, again, think about what to think about. As we go through these concepts, consider how they might affect both survivors and their loved ones. The concepts we'll cover today are, first, addressing the reality of cancer. It's really important to do so, whether it's the disease itself, the treatments and their side effects, and the very normal and very persistent emotions. The second thing we'll cover is it is critical to have what I call the crucial conversations. Among these many conversations are those between medical professionals and survivors, and those between survivors and loved ones. We'll talk about why to have them and a bit about how to do so. The third thing we'll talk about is that having hope is a meaningful aspect of addressing cancer. We'll talk about what hope is and how to build it. And the final thing we'll talk about is that many do not recognize that there are actually 2 parts of life for survivors and loved ones, and why and how to plan for each. We'll talk about planning both for the cancer part and the non-cancer part of our lives. So let's start with the first of these concepts, the reality of the disease. The moment of a diagnosis brings on a new reality for the patient and his or her loved ones. There's the reality of the disease itself and of its potential consequences, the reality of its treatment and of the side effects, and the reality of the onslaught of emotions. There is so much to take in and learn. There are so many decisions to be made. There's so much to deal with. The diagnosis itself can seem overwhelming, as can everything that comes with it. Yet at a time when it is most difficult to do so, that's exactly when we most need to address the reality. Philip Dick, you may have heard of him. He's a science fiction writer. He wrote, "That which, if you stop believing it, will not go away." That's what his definition of reality was. And in 1978, in an essay, writer and political activist, and at the time herself a breast cancer survivor, Susan Sontag, made the argument that no one who has been diagnosed should allow themselves to be distracted from the urgent quest for the best treatment of their illness. Although you might think that you or a loved one who received a diagnosis would immediately act to address it, unfortunately, that's not always the case. Just as our overall emotions following a diagnosis are inevitable and are normal, for many, so is the specific emotion of denial. Yet, we would do well to quickly recognize that we are in denial and strive, perhaps with the help of others, to move on to address the reality, as Sontag suggests, as an urgent quest. You may be thinking about someone that you know, whether from cancer or another diagnosis, who did not necessarily address the reality head on right away. Unfortunately, there are a number of folks in that situation. So address the reality is the first concept. Another part of that is to recognize that as real as the diagnosis is itself, it's the reality of the cancer treatments, which can be difficult in their own right and can be difficult because of the side effects. When we talk in a moment about putting together a cancer plan, we'll recognize that deciding on treatment options is critical, as is addressing the potential of side effects. Many of you or your relatives may have been affected by side effects. And again, we'll come back later on to talk about how to perhaps address those. Now, just as the diagnosis and the treatment effects are real, so are the emotions. We talked about denial. However, that is but one of the emotions to be expected. As I write in another part of the book's introduction, quote, we may begin with shock and denial, experience anxiety, fear, and stress, demonstrate anger, sadness, and defensiveness, exhibit symptoms of depression, and feel out of control and victimized. Each of these may come and go over time in varying degrees, and important to acknowledge, each is normal. And each is as real as the diagnosis itself. So although it is not easy to say and is difficult to do, it is imperative to acknowledge these realities and address them. The second concept I'd like to spend a few moments on is crucial conversations. Let's talk about those. So throughout our lives, we have the opportunity to have crucial conversations that will make a difference in our life circumstances. As but a few examples, we have conversations perhaps with a spouse about starting a family or planning for retirement, conversations with a boss about a work issue, disciplinary conversations with a child. All of these are crucial conversations. Many times these conversations are difficult to have and easy to convince ourselves not to have. Discussing cancer is one of those difficult times. So throughout the book, when we'll be learning about such discussions, I identify what I call a crucial conversation alert. And here are some examples of some of those crucial cancer conversations. When diagnosed, when diagnosed, who should you tell and how should you tell them? As I mentioned, I chose until the book was published 9 years later to only tell my wife, Ann, our children, and my sisters. A Cincinnati friend who I profile in the book chose to tell everyone he could using an internet application that I'm sure many of you are familiar with called Caring Bridge to do so. Neither is right or wrong. Each survivor should decide what is right for them. Regardless of who you tell and how, it is a crucial conversation and one that you should have. Among the most crucial and frequently difficult of conversations are the ones we have with medical professionals. The patient and loved ones need to make sure that they get all the information they need to fully participate in formulating their treatment plans. Research shows that after we are given bad medical news, we absorb very little of what is said afterward. In fact, interestingly enough, the same applies if we are given good medical news. So recognize that it is also difficult to give bad medical news. Some doctors do it well, others do not. So the information you are getting may or may not be as straightforward and understandable as you need. So here's several suggestions that I heard from doctors, survivors, and caregivers about making sure that you do, in fact, get the information you need in your conversations with medical professionals. One is, if you can, take some with you to each of your doctor visits to listen to what is being said. Secondly, you and or your listening partner take notes. This helps you concentrate on what is being said, so you're not blocked out once you hear perhaps bad or even good medical news. You're not being blocked out from what's being said afterward. So take notes, and this helps you concentrate on what is being said so that you can make a note for each key point. It also gives you something to review later. And one of the things that I had clearly not thought about when I was researching the book is I ran into a number of survivors and caregivers, as well as physicians, who said, make a digital recording of your conversations with your doctor and listen to it again later to make sure you've absorbed everything you need to. Ask if the doctor minds you doing so. Most will say yes, but if they don't, insist. And so that those digital recordings help you, again, review the information later. So given that the discussions with your doctor is one of those crucial conversations, one of the things you can do is prepare for each session with your doctor by formulating a list of questions, and make sure you get the time for him, from him or her, to get them answered to your satisfaction. In the book, I suggest a long list of potential questions for you to consider. Some examples are, how certain is the diagnosis? This might lead to a discussion of a second opinion. What is my prognosis? This answer will help guide you to making your life plans. What are my treatment options, and what do you recommend? And importantly, why? What treatment side effects can I expect, and what can I do up front to manage these effects? Unfortunately, although it happens less frequently now, it is not uncommon for someone to experience side effects only to learn that there was something that could have been done to mitigate those effects up front. And we talked about that a little bit before as well. A final question that you might want to consider, and again, this is among a list of a number that if you're interested, you can find in the book. How can I learn about and access clinical trials? Make sure that your doctor knows that you want to consider clinical trials, if you really do, and even if you want to consider clinical trials that are available out of town. Now, there are many cancer organizations, for example, one that I mentioned to you that I worked with on strategic planning called Fight Colorectal Cancer, that provide help in finding clinical trials. It may not be that your physician is familiar with all of them, although normally they are. So Fight Colorectal Cancer's program is called Clinical Trial Finder, which seems pretty obvious, but it does a great job of identifying those clinical trials nationwide for you to consider, if you think that's something that's important to you. So let's move on to another set of crucial conversations, those that should take place between survivor and loved ones. The reality of a cancer diagnosis brings on the reality that the relationship between the survivor and the loved one changes. There are many ways to manage the caregiving relationship, and one good way to start is by having what you might call an expectations exchange. There are a lot of topics to cover, and I list many of them in the book. Let me just give you some examples of things that you might want to have a conversation with as you enter this caregiving phase. Who will make what decisions? That's not always clear, but it's important to get clear. What is the caregiver's role at doctor's appointments? We talked about note taking and that sort of thing, but what else might the caregiver do during those appointments? What chores does the survivor need help with, and who will do them? Who else should you get involved in the caregiving, whether professional help or friends and family? Again, these are just a few of the conversations, and the intent of these crucial conversations is to make sure that you have them up front, so you don't get surprised by issues later on when they may be too late to deal with. Have these crucial conversations as soon as possible. And since we've talked about caregiving, let me share this with you. I thought this was pretty insightful from former First Lady Rosalind Carter. She said there are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who need caregivers. So I also address in the book that what caregivers can think about doing also to tend to themselves. The effects of caregiving on the loved ones are not trivial and need to be managed. Said another way, if you are or become a caregiver, what's your self-care plan? When we talk about life planning shortly, keep in mind that everything we'll talk about applies to both the survivor and loved ones. So that's a quick overview of crucial conversations. Let's shift our attention to the subject of hope. Each person's cancer experience is different. Different diagnosis, different prognosis, different treatments, different life circumstances, and different hope horizon. And hope horizon is a term I use in the book that can help survivors and caregivers think about having and building hope. I recently lost a friend to pancreatic cancer. He was diagnosed and died within a month. He had a very short hope horizon. I was diagnosed in 2010 and have a much longer hope horizon, having been extended by a successful round of chemotherapy. I contend, and I find the consensus to be pretty clear, regardless of the hope horizon, a survivor and loved one can have and build hope. The question then is, what is hope and how can we build it? Despite all the differences among individuals, I believe that the definition and ways to build hope have common themes across all of us. You can find many definitions of hope. This is the one that I developed after doing my research. Hope is taking action to develop the genuine belief that the future will be better than the present and or better than should be expected. For me, taking action and genuine belief are the key terms in that definition. So what action should we and can we take to develop the genuine belief? In that regard, I developed a three-part action-oriented model for building hope. Let's review this briefly, as it might be helpful to you whether it's you're dealing with cancer or some other issue. So the three parts of this model, and we'll go through each one, are building confidence, controlling what you can and creating a plan, and expecting changes and making adjustments to your plan. Well, let's look at each of these individually. The first part of the building hope model is build confidence. Having confidence makes it easier to be hopeful. And here are three things you can do. One is expand your knowledge. Learn as much as you can so that you can more meaningfully discuss your situation with your medical team and caregivers, and thereby participate more fully in your treatment plan. As but one example, when I was diagnosed, I began doing research and learned of a phase 2 clinical that had been conducted at the Mayo Clinic. The clinical showed that high doses of green tea extract had very positive results for CLL patients. I asked my doctor whether she would recommend my taking green tea extract and what would the dose be that she would recommend. Actually, she had not heard of the study. She did some research and she got back to me and she said, yes, take it. And the dose is 2,000 milligrams both morning and evening. And I had started taking the extract before she approved of it. But she also was able to tell me that there were no reported side effects. I actually saw positive results from the green tea even before going through my eventual rounds of chemotherapy. So expand your knowledge and learn what you can. Again, it enhances the conversation you're having with your medical team. A second thing is to get to know your medical team, both as a professional and on a personal basis. If you find that you cannot say with confidence that you trust your doctor, make a change. That may be a difficult thing to do, but remember, this is about you and or your loved ones. The final thing is to explore your spirituality. Now, whether yours is based on organized religion or not, many physicians are convinced that spirituality can enhance healing. And actually, and I was surprised to learn this as I was doing the research, Many medical schools are actually including the concept of spirituality in their curriculum. So the first part of the model is to build confidence. And when you do, that will be part of giving you more hope. The second part of the model is to control what you can and create a plan. Focusing your energy on the things you can control. And here's some of what those can be. You can focus on building your support team. This includes your medical team, your caregiving team, perhaps your complementary health approach team. There's a section in the book that guides you through the team building process. Another thing you can do is participate fully in developing your treatment plan. This is not about the doctor telling you what to do and you blindly following his or her dictates. This is about fully understanding the options and making the decisions about what you want to do and not do, obviously with your medical professionals. Third thing you can do, we've already talked about, is have the crucial conversations with your team members to make sure everybody's on the same page. And finally, mindfully create a non-cancer life plan. And we're going to talk about that shortly. So the second thing you can do is control what you can and create a plan. The final thing is part of the hope model of building hope is to expect changes and make adjustments. And here's a piece about this that I wrote for the book. Quote, what separates true hope from wishful thinking is the expectation and acceptance that life circumstances change. The path to achieving our goals and dreams is often fraught with unanticipated roadblocks, but changes can be positive as well. In either case, when life's ups and downs occur, it is time to alter your plan. I used to work with a gentleman at Procter & Gamble whose statement was, a plan is only something from which to deviate, but it's important to have that plan. So taking these three elements into consideration, it's important to build hope. So let's talk about the planning part of this discussion, and that'll get us closer to questions and comments. When someone is diagnosed with cancer, it is not uncommon for the reality of the cancer, its treatment, and the emotions to become, or at least feel, all-consuming. But as we do throughout our lives, we aspire to improve our lot, whether we have cancer or not. The opportunity in the presence of cancer, whether we are the survivor or a loved one, is to recognize that yes, cancer is now part of our lives, but that we also have a non-cancer part of our lives. The opportunity is to make sure that we have a good plan for each part, both the cancer part and the non-cancer part. And let's talk about each of those. So the cancer plan can include things like deciding on your treatment plan, whether conventional medicine or complementary or an alternate approach. By the way, this is a controversial subject. Some advocate alternate approaches to the exclusion of conventional medical treatments. If you want to consider these approaches, I think it calls for a meaningful, crucial conversation with your doctor and with the practitioners of these alternate approaches. So another thing that you can do to build your cancer plan is to build your medical and support teams. We talked about that previously. And the last thing is how to ensure, as part of your plan, how are you going to assure that you adhere to your treatment plan? Now, this can be a challenge and may require help from others to make sure you stay on track. You might think that treatment adherence is an obvious thing to do, but the data show that for both cancer and other diseases, non-adherence is a huge problem. So step number one, build your cancer plan. The non-cancer plan approach is derived from my retirement life planning work. In the book, I review what I refer to, as I mentioned, the 10 key elements of a fulfilling life, and I share a number of simple planning tools you can use. We don't have time today to get into the details of the key elements or the planning tools. But one thing I do want to emphasize is that it's important both for the cancer plan and the non-cancer plan to write your plan down. And why is this? The research, again, is consistent. If you write a plan down, you are 5 times more likely to do that plan. So in summary, we've talked about dealing with reality, having the crucial conversations, building hope, and developing your plans. And it looks like we have time for some questions, but before we get to them, let me share with you my contact information. I'll leave this up for just a bit. If we can't get to your question or comment, or if there's something you want to contact me about afterward, feel free to do so. I would look forward to hearing from you. So again, thank you to the folks at the Mirowitz Center at Covenant Place. I'm going to unshare my screen, and we'll take the risk for people asking questions and making comments. If you want to do that, unmute yourself. I guess, Judy, they can do that.
Yes, they can.
Okay. And so if you have a question or comment, just do it, and just let's work hard not to try and talk over each other. So does anybody have any questions or comments?
Alan?
Yes.
Apparently my screen has gone back to a stock photo, so it makes me look good. But the one comment I had, and unfortunately the internet failed me about 5 minutes ago, or 3 minutes ago, whatever it was. So I missed some of it. But one of the things that I think I brought up with you when we were talking, and again, possibly because I'm a biologist and I've worked on some of these things involved with cancer, my advice is always to get as much information and learn as much information as you can about the disease. And just, as I say, I think I mentioned to you, because I'm a biologist, I don't know what I know that other people don't generally know. So I may have had some definite advantages, but reading and going on internet to actual scientific sites and medical sites, not just the popular stuff, but PubMed, and reading about research and reading about from the NIH can give both the caregiver and the patient a lot of information that is useful. And
yeah, Don, thank you for that, and thank you again for being part of this book project and allowing me to share your profile in the book. The reason everything you said is right on. A reason that I emphasize learning as much as we can is sometimes when you're not a biologist and the information can be daunting and a little bit, more than a little bit, very intimidating. But I think it's important to fight through that and follow your advice. We all know that when we go to do research on the internet, we have to pay particular attention to whether it's credible information or not.
yes,
There are so many, you mentioned the NIH. It's one of the reasons I went to the Mayo Clinic site when I found the clinical trial that has helped me. So there are places you can go that speak in layman's terms. The other thing that I think I would emphasize here, Don, and thank you for bringing this whole subject up, is there are a number of organizations, and each cancer type tends to have its own, that does a great job of providing information in layman's terms. And many of them also have phone numbers that you can call and talk to somebody who's either had the disease or is a medical professional. And I know the Leukemia and Lymphoma Society has those features. So does Fight Colorectal Cancer, and I'm sure the others do as well. So yes, get as much information as you can. Take that information with you to your physician and have a conversation that's more than you just sitting there listening to what the doctor thinks you ought to be doing. Other questions? Yeah, thanks, Don. Other questions and comments? Yeah, Ronnie, unmute yourself.
I wanted to say that I think even though the book is written about cancer and survival and family issues, I think that especially the back part of the book can also help anybody in any family that's going through dealing with Parkinson's or Alzheimer's or any other critical disease, making the plan. And a lot of the stuff that you recommend for cancer can also be applied
Does
to.
he have all that in there at the?
I don't remember.
That's it.
Hey, Marty Weiss, put yourself on mute. Thanks. Yeah, I cut you off there, Ronnie? Were you done?
Yeah, I wanted to share that because many of us may not go through cancer. You know, we know people, but there's also other diseases that come in our lives as well as we age.
Yeah, Ronnie, thank you for that comment. As I was talking to these medical professionals that I came in contact with through my consulting work, they emphasize that consistently. That as they talk to their colleagues, they who are working in other areas, they find that the issues and the resolution of those issues frequently have very common themes. And the way you described it, I should have contacted you before I wrote the book because you did a better job than I did. So thanks. Other comments? Don, I see you're back. Any other comments or questions?
Martin, do you have a
Yes,
question?
sir. Yeah, I just want to make a comment. As a retired physician, it's difficult these days to be a physician that can meet all the needs of your patients and their family. Usually have maybe 15 minutes to review the labs, the scans, come with a game plan. Then you have to type up your report. You have to click multiple boxes to maximize reimbursement. Then you have to put in your orders and then go on to the next patient. And you oftentimes just have time just to treat the immediate needs of the cancer. And the other needs aren't addressed very well. You know, when someone has cancer, ideally you have a whole team as a support system, maybe a navigator, a psychologist, social worker, someone in the spiritual world to support you, someone to help organize the care you might need and actually support the caregiver, maybe a financial advisor. You maybe have to make some legal decisions. And I think as a physician, we often fall short of that, just the way our healthcare system is set up, where we're trained more to treat disease and oftentimes treat people. I was uniquely trained in rehabilitation medicine, where we did have a team approach, but that was the exception, not the rule. And I think people ought to seek out as much support as they can get beyond just the traditional physician office.
Yeah, Marty, thanks for that. Two comments in response. One is, you know, I mentioned a number of the questions that you might want to consider when you go talk to your physician, and be prepared to ask them when you do get time with your doctor. If you have those questions prepared in advance, it can tend to focus on the things that are important to you, so that the doctor, and I recognize that they have a lot to do in a relatively short period of time, they can get to your concerns more quickly than if you go in without a set of questions in your mind. I go in with them with written questions, so I make sure that I get them all answered. The second thing, Marty, relative to your comment is when I was working with the University of Colorado Cancer Center, they have their cancer center has within it an entire team. And at this moment, I can't remember exactly what it's called, but I profiled them in the book. But that has everything from social workers to financial folks to whatever. And so Don, you have experience with that as well, right? Get off of mute, Don.
Sorry, it's an integrative approach.
Hello.
Yeah.
I'll just take a second. My situation with my daughter Rachel was most unusual because she was in her fellowship in oncology at UCSF. So her doctors gave her so much time. She trusted them all. We had access that probably most patients do not ever have. And my daughter even said it would be nice if other patients could have that kind of access. But being able to talk to doctors who gave her diets, Donald Ira Abrams gave her a diet which was basically only Oriental mushrooms, no dairy, only organic food, minimally processed. She got information. She got information on acupuncture. California being the state that it was, she got information on other substances that might help some of the pain and things. But yeah, having a full team and having absolute access to sociologists, to geneticists, to everybody can make a big difference in how you
Yeah.
feel.
Thank you for that, Don. Yeah. And
Hello.
I've been told by, I was told by the folks at the University of Colorado that the program that they had put together, the adjunct to their cancer center that provided that integrative medicine approach, is something that most cancer centers either have begun to do or are now putting in place. So I think that, thank you for sharing your situation and Rachel's. I think it's going to become more common. And Marty, to your original point, to where the physician doesn't have to worry about that specifically, but there will be more and more accessible support at every cancer center. Stephen
Hi,
and Judy,
Alan.
I think
This is Nina.
Nina has a question. Let's take Nina's question.
Thank you.
Hi, Nina.
So, I have listened to this very carefully, and this has been an interesting Zoom call for me because I have had a lot of difficulty either getting the sound correct so that I could hear it, or when I did that, then the picture went off. And so I've listened and looked, but I appreciate what Don said. And because his daughter had beautiful access to so much. But I will tell you that us regular, Jack and Jills don't exactly have that. Now, I'm a retired therapist. I have 30 years in back of me of working in the field of disability with every kind of disability you can imagine. So when I was diagnosed with bladder cancer, I thought I could move forward through this. Wrong. I finally got to the point where I was having so much difficulty, I felt, communicating with my doctor, i.e., my doctor wasn't listening to me, that I brought a trusted friend in, and she actually did the communication. She facilitated back and forth, and it was very helpful. But not everyone has access to that either, or that it happens in the same way. So while I think stressing hope is such a critical factor from the get-go, I think it's also realistic to say to people, this is going to be one of the most difficult jobs you have ever had. And it's not because people don't necessarily understand. It's just that the access to some of the things is not going to be available. The other thing that struck me, and this is sort of interesting in this time that we're all sharing, of basically an overall sense that we are not in control. Something or someone else is in control. And COVID has wreaked bad on many kinds of things, businesses and people. And when you got to the point where you started to talk about the responses that we may have to getting the news. And you said denial. And then you referred back to the beginning of your book and you read, a list of things that might occur. The first thing that popped into my head as I was listening to that was coronavirus. And for a little while, as you continued to talk, all I could think about was corona. Because
So Nina,
we're sitting here in the midst of this, and along with things that people may be coping with in terms of cancer, we've got this going on. It's tough.
Absolutely. It absolutely is, Nina. And a couple things come to mind. One is, and I give this offer to anybody else who's on the call. I normally don't, when I'm making a presentation, work from a script, but I'm sure you could tell throughout, that's what I was doing. Nina, I'll send you the script. So as you might have missed some of the stuff because of the technology issues, I'll send it to you. If there's anybody else who wants a copy of it, let me know and I'll send it to you as well. The other thing is that part, okay, Don, that part of the hope model is why I put in there, control what you can and make a plan. There are some things that are just out of our control, and it's an energy drain to try and affect those. So asking yourself the question, what is within your control, and what do I want to do about that? Whether it be corona, whether it be cancer, whether it be some of the other things that Ronnie was talking about, it is part of the key to building hope. So we've actually, I hate to do this, but we've actually run over time here, Judy and Stephen. So yeah, so I would appreciate everybody for joining, and again, the Mirowitz folks for making this happen. Thank you. And if anybody wants to get in touch to either comment or ask questions or get a copy of the script, I'd be proud to do that. So
And
thank you.
Thank you, Alan. Thank you so much. We really appreciate you today. Also, everyone, I want you to know that this has been recorded and will be on the Mirowitz.org website in the next couple days. It takes me a couple days, but Alan, thank you so much. It was very informative.
My pleasure. Good to see you all. I mean, really see you all, most of you.
Thank you, Alan.
Thank you. Good to see you, Barb.